So let's look at a few things when we're talking about our drugs affecting the cardiovascular system. First, remember that all of the chapter outlines and the notes that I teach off of are right here in our D2L course under week 5. And then when we're looking at these, it looks like a lot. I do understand. 6 chapters looks like a lot, but they go together. They almost dovetail nicely. So if you think about hypertension, which is high blood pressure can lead to chest pain. Chest pain or failure of the heart to work well because of myocardial infarction can lead to heart failure. Another problem that we associate with heart failure, or another issue, is the electrical conduction of the heart, which is antidysrhythmic drugs. And then the reason why we have coagulation modifiers are often related to our dysrhythmias that occur. And then finally, the anti-lipidemic drugs look at cholesterol and how cholesterol impacts the cardiovascular system, specifically hypertension. So they go together. So don't think of them as separate chapters. Think of them as all going together under the cardiovascular system. So when we're looking at, starting with chapter 22, we're looking at our antihypertensive medications. Be sure to read through your chapter objectives. And then our key terms here, paying attention basically to hypertension. I don't really differentiate between essential hypertension or hypertension. You'll see a lot on orthostatic hypotension, not just in this class, but from here out you'll have a lot of information on orthostatic hypotension. Prodrug, we've had this before, but that's that drug, when I give it, it's inactive, and then the body has to metabolize it to make it active, which means my liver has to be functioning well. So good. NCLEX question would be if a person has problems with liver function because of another illness, think hepatitis, then they might not be a good candidate for a prodrug. And then we are going to look at, let me pull my outline over. We're going to look at drugs based in different blocks, whether they're adrenergic drugs or angiotensin drugs or angiotensin II receptor drugs or calcium channel blockers or diuretics. And what you're going to notice is that it looks like a lot on this one, but we'll tend to use these over and over and over again in this section of the textbook where we're talking about cardiovascular drugs. Tells us a little bit about cardiac output. So go back to your anatomy and physiology and understand what's happening with the heart and why we might have high blood pressure. I usually want you to think about either that cardiac output, the heart, what the heart's, how effectively the heart's pumping, versus this systemic vascular resistance. So I think about that systemic vascular resistance playing a role in how well my vessels dilate and constrict. If they're constricted all the time, that's going to make my blood pressure go up. Think about how hard it would be to push water out of a real small hose versus a large hose. So that talks about that systemic vascular resistance. And then it goes into a little bit of difference about which drugs work well for different reasons. I won't get that specific about it. I won't ask you which one would I take for systemic vascular resistance versus which one would I take for cardiac output. When we're looking at these, most of them have a nice little acronym that goes with it. So we'll talk about them in the angiotensin converting enzyme. You guys know me well enough to know I slaughter most of my words. So angiotensin converting enzyme medication will be called ACE inhibitors. Angiotensin receptor blockers will be called ARBs. Calcium channel blockers are CCBs, and all that will make it a little bit easier for us to get through this chapter. Again, I'm not going to stress about the different, I'm not going to ask you, this is an adrenergic drug. I'll ask you the medication itself. So let's scroll on down to in the mechanism of action, it does tell you a little bit about where they're working and how they work to reduce that overall blood pressure. So we'll talk about that with some of our specific drugs. So for my first group of drugs, this adrenergic drugs, there's a couple of different types underneath that, but we're going to look at it as a whole. So my adrenergic drugs, we use those in our individuals to treat hypertension. You'll notice that we can use it alone or with other medications. And then they're contraindicated, obviously, with my individuals with drug allergy, and they may also be contraindicated in individuals with heart failure or that concurrent use of our MAOI inhibitors. Think about those MAOI inhibitors, and automatically I want you to think about what food you can't have when you've got those MAOI inhibitors, like our pepperoni, cheese, beer, wine. Also contraindicated with severe liver or severe kidney disease. Severe being your key here, because some patients, if they have a mild kidney problem, will still be on our adrenergic medications. Adverse effects with this one, they've even got it bolded here. Orthostatic hypotension is a big one. Orthostatic hypotension always predisposes that person to falls, so keep that in mind for safety. Also associated with the first dose syncope, which means that hypotension is so extreme for that first dose that sometimes patients will not only faint, but they will actually lose consciousness with that one. So we'll want to make sure that they understand that and they take that first dose where they're being monitored. And then make sure we're educating them to change their position slowly so that they don't have subsequent fainting spells or lose their drop their blood pressure real quick. My dad just did this the night, called me right in the middle of the night because he just fainted, and I'm positive it was because he had this orthostatic hypotension, got up too quick. Also notice up here that it does tell us we have some reflex tachycardia that's noticed with it, dry mouth, dizziness, drowsiness, depression, edema, constipation, sexual dysfunction. So those are some of the ordinary things that we see with this medication. Interactions, these particular drugs will interact with other CNS depressants, such as alcohol or benzodiazepine or opioids. So it's going to compound that sedated effect of other CNS depressants. When we go down to our drugs specifically, I'm going to mention 4. My first one is this clonidine. On my clonidine, one of the things I wanted to point out with this one is when we have clonidine via patches, we want to make sure that we take off the old one before we replace it with a new one so that we don't have additive effect there. So take off the old one, add a new one, and then for our patients not to stop this one abruptly, because that could lead them right to that severe rebound hypertension. In my next group under this umbrella of our adrenergic drugs is my alpha-1 blocker, and we've got one drug here, and that's my doxazosin. On my doxazosin, it reduces that vascular resistance and by dilating our arterial and venous blood pressures. So whenever we dilate, that's going to open that up and reduce that systemic pressure, systemic resistance. We want to make sure that we're educating our patients that when they take this, the matrix, which means the thing that the capsule is actually made out of, it's kind of gelatinous. When they take that, they will actually poop out the matrix of that capsule. So tell them not to be alarmed with that. That's going to be a normal thing that happens. My next one are my dual action alpha and beta receptor blockers. My drug of choice here is my cardavilidolol. On this one, we're going to see it again when we get to our heart failure chapter, because it does well with those patients also. So it decreases our hypertension. Also use it again with our heart failure patients, but look at some of the contraindications on this one. So contraindicated also, obviously, when we have drug allergy, but I wanted to point out the severe bradycardia and asthmas being 2 of them that we see frequently that negates when an individual is able to take this medication. I think there's one more. Oh, beta blockers with that one. Okay. My last one under the adrenergic umbrella are my beta blockers. On this one, I want you to think beta blockers typically end in OL. We'll talk about these more in chapter 23 and 25. So see how this ends in an OL. Nebivolol, my drug of choice for my beta blocker. Useful here to reduce heart rate and vasoconstriction for this one. We want to make sure, my thing to remember with this drug is not to stop it abruptly, and if they do discontinue it, we want to make sure they taper their use over 1 to 2 weeks. My next thing that we're rolling right into, so again, I'm going to pay attention here. I did my adrenergic. Now I'm going to go into my ACE inhibitors, so angiotensin converting enzyme inhibitors. They do three things that we see quite frequently. They cause a dry cough, non-productive, just a dry cough. They're associated with hyperkalemia and sometimes renal failure. So keep those things in mind. And it mentions here at the bottom that of all the ACE inhibitors, all of them except these two specific ones are prodrug, which means my patient needs to have a good functioning liver for the drug to be effective and work well. All of these work by my ACE inhibitors do exactly that. They inhibit that conversion of AI to the angiotensin system, if you'll remember that back from anatomy and physiology. When they do that, they decrease systemic vascular resistance. So we'll use these on our patients with hypertension, and then we'll also see them after myocardial infarction very frequently. Usually they are contraindicated if my patient has drug allergy or angioedema. And then note this next piece here, if they have a baseline potassium of 5 milliequivalents or higher, they might not be good candidates for ACE inhibitor. Think about our normal range of potassium being 3.5 to 5 because it does predispose that individual to hyperkalemia. So keep that in mind with those guys. Major adverse effects are those fatigue, dizziness, mood changes, and headache. And then this is the one that patients complain about all the time, is a dry, non-productive cough. And I mean to the point where they want to change their medication because that's so persistent with that one. Also want to make sure we're watching them for their renal function because sometimes it impacts their ability of their kidneys to diurese well. A pronounced symptom of overdose of our ACE inhibitor is that hypotension, so we want to make sure that we're monitoring that blood pressure. It is something we can delegate out, but I would want to give parameters to my patient caretaker, my CNA, to come back and tell me what that blood pressure is. Got a little bit of information on interactions here, and my drug of choice for this, I've got two we're going to look at. My captopril is the first one. This is my prototypical. It's the one that they almost always start patients on. It's very effective for our hypertensive patients. We typically will give it, assign it, especially after an individual's had an MI. The negative aspect about my captopril is it has to be given frequently through the day, which is a negative aspect. It's hard to have compliance with that one. Versus my next one, my enalapril. It's available orally and parenterally, so a lot of times we'll start them parentally on it in the hospital and then switch them over to orally once they're being discharged to home. Okay, it is known to increase survival after the incidence of an MI. Next video we'll cover our ARBs, ARBs, and we'll pick it up right there.